Welcome back to Home Health Management Solutions, where we break down compliance, documentation, and Medicare requirements in a way that's simple, clear, and practical for everyday home health operations. Today, we're diving into one of the biggest headaches for agencies: billing and denials. Whether you're an owner, biller, clinical manager, or just learning how home health claims work, this video will walk you through the top reasons claims get denied and exactly how to fix or prevent those issues. Let's get into it. What is medical review? Medical review is the process used by Centers for Medicare and Medicaid Services, CMS, and its Medicare Administrative Contractors, MAC, to evaluate whether services billed to Medicare are reasonable and necessary, properly ordered and certified, and supported by complete and accurate medical documentation in accordance with Medicare coverage, payment, and coding requirements. If documentation fails to support criteria, Medicare issues a denial under a specific denial code that represents the reason the claim could not be paid. Types of Medicare review. 1. Pre-claim or prepayment review. This occurs before Medicare issues payment on a final claim. Documentation is reviewed prior to payment. Claims may be held until records are reviewed. The goal is to prevent improper payments up front. 2. Post-claim or post-payment review. This review occurs after a claim has already been submitted or paid. If documentation does not support coverage, Medicare issues partial denials, full denials, or payment recoupments. This is where most agencies experience financial takebacks. ADR. Additional documentation request is not a review type. It is the formal request Medicare sends to obtain documentation during a medical review. Failure to respond timely results in automatic denial. What Medicare looks for in all reviews. Regardless of when the review occurs, Medicare evaluates the same 5 core eligibility elements: valid face-to-face encounter, physician certification and plan of care, homebound status, medical necessity of skilled services, and complete consistent documentation. Below are the top denial reasons for home health claims. Records not submitted timely. This denial occurs when requested medical documentation is not submitted within Medicare's required timeframe during a medical review. As a result, Medicare was unable to evaluate medical necessity. Late submissions often result in auto-denial, regardless of care quality. Prevention. Centralize medical review tracking for all requests. Monitor claim status regularly. Track submission deadlines carefully. Submit records within 30 days of an ADR. Claims auto-deny on day 46. Submit complete documentation in one organized package to avoid partial or insufficient responses. Respond immediately upon receiving a review request to allow time for corrections if needed. Include identifying information, ADR or review request, with each submission. Submit responses separately for multiple requests. Mail records to the address listed on the review request to ensure proper routing. No plan of care or certification. The services billed were denied because the home health agency did not submit a valid physician-established and approved plan of care and/or did not include the required physician-signed certification or recertification in the medical records provided for review as required by Medicare. Prevention. Ensure a complete plan of care is established, signed, and dated by the physician before billing. Confirm the plan of care includes all the required elements of a valid plan of care. Submit the signed certification or recertification with all submissions. Verify the physician certifies that the patient is homebound, requires intermittent skilled services, and is under a physician-directed plan of care. Obtain certification when the plan of care is established and recertification at least every 60 days. Maintain certifications on file and be prepared to submit them upon request. Face-to-face encounter requirements not met. The services billed were denied because the medical records submitted for review did not contain sufficient documentation of a required face-to-face encounter. Medicare requires that the face-to-face must occur within 90 days before or 30 days after start of care, be related to the primary reason for home health, be performed by an allowed practitioner, support homebound status and skilled need. Ensure the face-to-face encounter occurs within 90 days before or 30 days after the start of care. Submit documentation showing the encounter was completed by the certifying physician or an allowed non-physician practitioner, including the date of the encounter, and includes a brief physician narrative explaining how the encounter supports homebound status and the need for skilled services. Face-to-face must be signed and dated. Do not bill if face-to-face documentation is invalid or not yet obtained. No physician order for services. The services billed were denied because a portion of the claim were incomplete, missing, or not obtained prior to the services being rendered. Confirm that physician orders for all services rendered and billed are included in the medical record submission. Ensure all physician orders are obtained prior to delivering services and are on file before submitting the final claim to Medicare. Information provided does not support the medical necessity for therapy services. Ensure the medical record clearly supports the medical necessity of all therapy services billed. Documentation must demonstrate that the services are reasonable and necessary for the treatment of the patient's illness or injury, reasonable and necessary to restore or maintain function affected by the illness or injury, and sufficiently complex that they can be performed safely and effectively only by or under the general supervision of a skilled therapist and require the clinical skills of that therapist. Include all required therapy documentation, including the initial therapy evaluation, the current therapy reevaluations for the episode under review, and any prior therapy reevaluations relevant to the episode. Visits, supplies, DME billed, not documented or not documented as used. The documentation submitted did not support the services billed and requires correction. For example, physical therapy services were billed, but the documentation reflected services provided by a physical therapy assistant. A corrected hard copy along with the medical records must be submitted. Note: services billed in error cannot be revised or deleted once an ADR has been issued. However, they may be requested to be denied as billed in error. Ensure that documentation supporting all billed services is included with the medical records submitted in response to an ADR. Verify that all documentation contains legible, dated signatures. If any signatures are unclear, include a signature log with the submission. Information provided does not support medical necessity. The claim was fully or partially denied because the documentation submitted did not adequately demonstrate the medical necessity of the skilled services billed. The records failed to show a reasonable potential for improvement, a change in condition, or a continued need for skilled intervention beyond initial teaching or observation. Submit complete, legible, and signed documentation supporting all skilled services billed. Use accurate ICD-10 codes that justify the need for skilled care. Clearly document why skilled services are required, such as new or worsening conditions, hospitalizations, or medication changes, acute changes requiring assessment or treatment modification, complex care needs, unstable caregiving situations, or complicating conditions, initial teaching, reteaching, or skilled interventions, e.g. injections, catheter care, or complex wound care. Documentation does not support homebound status. The services billed were denied because the documentation submitted did not adequately support that the patient met Medicare's homebound criteria. A beneficiary is considered homebound when both of the following conditions are met. Due to illness or injury, the patient's ability to leave the home is restricted and requires the use of supportive devices, such as a cane, walker, wheelchair, special transportation, assistance from another person, or leaving the home is medically contraindicated, and the patient has a normal inability to leave the home, and doing so requires a considerable and taxing effort. Ensure submitted documentation clearly demonstrates the patient's need for supportive devices, assistance from another person, or that leaving the home is medically contraindicated, and the patient's normal inability to leave the home, and that leaving the home requires a taxing effort. Other factors that may affect reimbursement, cause denials, or result in payment delays include notice of admission submitted late. CMS requires NOAs within 5 calendar days of the start of care. Submit notice of admission as soon as start of care visit is completed. Set up EMR alerts for incomplete NOAs. Create a backup process if the primary biller is out. Review daily admissions list against NOAs submitted. Orders, frequencies, and plan of care errors. Common problems include visits exceed ordered frequency, orders not signed before billing, disciplines billed not ordered, orders missing treatment details, match ordered frequencies to billed visits, audit plan of care against visit utilization, track outstanding plan of care signatures weekly, follow up with physician offices proactively, use an orders dashboard in the EMR and educate staff on frequency compliance. OASIS and documentation misalignment. OASIS responses contradict with the visit notes, functional abilities, skilled needs. This raises credibility concerns in the medical record. Perform OASIS validation audits, ensure narrative notes support scoring, and train clinicians on consistency. OASIS not exported or with fatal errors. Claims deny when OASIS isn't accepted by IKEYS. Check IKEYS validation reports daily. Correct fatal errors immediately. Ensure clinicians lock assessments on time. Assign one clinical reviewer responsible for OASIS audits before export. Incorrect primary diagnosis. Issues include primary diagnosis not supporting skilled need, unacceptable primary codes, missing laterality or specificity, undocumented comorbidities. Review coding against face-to-face documentation, plan of care and visit notes, ensure ICD-10 specificity, use coding software that alerts for improper coding and have certified coders to ensure coding compliance, clarify diagnosis with physicians when unclear. Always ask, does this primary diagnosis justify skilled home health care and supported by the face-to-face encounter? LUPA issues, visit threshold not met. If the patient does not meet the visit threshold, reimbursement drastically drops. Ensure visits align with plan of care frequencies. Track missed visits daily. Implement procedures for same-day rescheduling. Case managers should review weekly utilization reports. Medicare secondary payer mistakes. Incorrect coordination of benefits. Always verify insurance at admission. Update MSP status with every hospitalization or change. Correct issues before claim submission. Teach administrative staff how to read a Medicare eligibility report. Duplicate claims or overlapping care occurs when another agency billed first or patient is already in a facility. Always confirm patient status at each visit. Check OASIS transfers to discharges promptly. Coordinate with receiving agencies. Best practices to avoid medical review denials. Have a strong front-end eligibility review process. Perform weekly and ongoing internal audits before billing. Use documentation tools that enforce medical necessity. Teach clinicians on how to document strong measurable documentation habits. Track denial reason codes and root causes for quality improvement. Validate eligibility criteria and timeframes before billing. Have a collaboration between billing and QA team. Invest in staff training and qualified QA personnel and coders. Medical review denials are avoidable if you understand the documentation expectations and implement strong systems. Start today by reviewing your top denial codes and building corrective processes into your daily workflow. Thanks so much for watching. If you found this video helpful, give it a thumbs up. It really helps others find it too. Don't forget to subscribe so you don't miss out on more tips and resources. Looking for easy-to-use digital tools for managing home health? Check out my Etsy shop. Link is in the description. If you have questions, ideas, or want to share your experience, leave a comment. I'd love to hear from you. And feel free to share this with anyone who might find it useful. See you in the next video.